just not rewarding. But this is what's needed. We need to play this game. Because if we just give anecdote after anecdote after anecdote, we'll be locked in a wee cupboard and they'll take the key away and they'll say, you know, that's it. That's the LDN cupboard. We keep all the mad doctors in there that think this is good. You know, we need to play this game. So we're then faced with multiple challenges, one of them being it's a very difficult thing to study because what we're actually looking at is trying to prevent MS getting worse. And how do you study that? You know, that's a long, long study. The longer the study, the more expensive it is. Somebody mentioned earlier on about, you know, why are these studies short? They're short because it keeps it cheap. If you do a study over 5 years, you know, you're talking millions. You know, because you've got to follow people up, you've got to pay nurses, you've got to pay it becomes very expensive. So you have to compromise, and that's why a lot of the studies are short, is because if you're going to get funding at all, the least money you ask for, the better. So we're looking at this disease, which is very gradual change with the progressive forms, but it does change. And the EDSS, which is the Expanded Disability Status, despite the fact that that Nordvik study showed a 25% improvement, it is very hard to shift it. And of course, with LDN, it's going to be really hard to shift it because we're trying to stop deterioration. Although you do get, as Skip said in his talk, you get people who improve, you know, that's probably because you know, there's natural recovery when the immune system backs off and stops beating you up. So there is somebody, you know, it's not spectacular in most cases. Notice people are not cutting the grass and chasing the bikini-clad sunbathers. But I had two patients. We started at 1 milligram. You know, we started at 3 to begin with. We had quite a lot of people getting side effects. We cut it down to 1. I was interested to see that's not that dissimilar to what Skip was talking about. And I had 2 patients in a row that came into my clinic. They were both just started on it, and they both were on 1 milligram, both male, funnily enough. And the first guy came in and said, that stuff's really good. That's good. And he said, you know, I'm not up at all at night now going to the toilet. And I says, all right, how often were you up at night? 12 times a night. He was just up and down all night. And he said, I'm not up at all now, on 1 milligram. So I thought, now that's measurable. And then the next guy came in, and he said, it's good stuff, LDN. And I said, yeah. He says, I'm not up at all at night. I thought, have you been talking in the waiting room? Conferring notes. He was up 6 times at night, and then he wasn't up at all. So I thought, either I'm extremely thick, or there's a message here saying, you know, maybe we should be studying bladder dysfunction as a measurable thing, which we can, you know, it's easy to do. So lots of patients have improved bladder symptoms. I didn't realize how important that was, having never had a weak bladder. But when you talk to people, you think, God, their whole plan in their life was all around where the toilets were. You know, we'll go there and I'll stop at the little chef and I'll stop there. And it was all planned ahead because all around the toilet. So it makes a huge difference to quality of life if you can actually go for longer. So and of course, we thought this is actually quite easy to do. We'll do a urinary frequency chart, and you just tick it off, and went and saw the stats guy, and he told me what we needed to do. We're adding in the MS quality of life questionnaire. You know, well, we're going to do that anyway, but it's nice to see that's the San Francisco study saw an improvement in that. And again, I think there is a link between having improved bladder control and having improved quality of life. The statistician tells me we need 120 people in the study, which is a lot. And as a GP with 6 patients, you know, I'm going to struggle to get 120. But, you know, that's what we've got to go on, because if we can show that the frequency of urine, frequency of going to the toilet goes down from 10 times a day to 7 times a day, that will give us statistical significance, and, you know, it makes the study work. So it's 120 or nothing. And it's going to be a double-blind, randomized controlled trial. It has to be, because anything other than that will just get laughed out of court. So if we're going to do it at all, we're going to spend 5 years of my life trying to get a bit of a study going. I want to make sure that at the end of it, I don't cause uproarious laughter in every single neurology department, and they all went, I knew that was a lot of rubbish. So my next challenge was, how do I get a consultant neurologist on board? Because it's very difficult to get funding if you've not got a neurologist, and I'm a GP. So I started phoning up neurologists, and I wouldn't advise you do this, actually. You know, not an awful lot of success. But then, God bless the Irish, I phoned Dr. Jonathan O'Riordan up at 9 Wells. I was telling David I prepared for my lecture today by singing Irish songs till 1:30 in the morning in the Casey's Bar in downtown LA. If anybody wants to go, it's good. So I phoned up Jonathan, and he immediately just went, oh, no bother, Tom. And I thought, what? You know, all these guys going, oh, you know. And he went, no problem, I'll do that. And he runs, he's in charge of the MS Research Centre at Dundee, and he does a lot of research. But I thought he was a good guy because he's doing a study on the best bet diet. They've just finished it. So he's a bit more open-minded than most of the guys. So I said to him, our plan was 3 centres, 120, 40 in each centre, probably manageable. So we've got Glasgow. I'm going to do the Glasgow end. He's going to do Dundee. And I said, is there anyone else I should phone? And he went, no. Save your breath. He says, don't bother. So I didn't. I saved my breath. It was saved me a lot of phone calls. But we have got the clinical research facility in Glasgow on board. We've got who, if we can get accredited funding, that is, and you know we're very close to getting that. And we've got the bioscience statistics, and we've got a lot of support. We've got a lot of good researchers who professionally do research involved in this now, because you just cannot do it yourself. There's so many different hoops you've got to go through. Linda Elsegood, who some of you will know, has been at this conference a couple of times, was very supportive, as you would expect. I mean, she's virtually single-handedly runs a charity, the LDN Research Trust, and at one point we thought that was how we were going to get the funding, but it's complicated. If you get accredited funding, then that opens up a lot of resources to you. If you don't get accredited funding and just somebody comes and gives you a big wad of dosh, it's quite hard to get the other support that you need to get it into a journal and all the rest of it. So we probably won't have money from the LDN Research Trust, but that's just because of the way it works. The MS Society threw it out straight away, absolutely. And I knew they would. I just had to go there first in order to get rejection so I could then go to the next funder who I really wanted to go to. But, you've got to play the game. And they emailed me on a Monday. I'm in the middle of my surgery, and Monday morning, really busy, and said, we need to have this by Wednesday, 12 o'clock, 8 copies of your thing in London. So I had to drop everything, got it all together, sent it down, and letter back saying, no, sorry, not a good enough design. Double-blind, randomized controlled trial, not a good enough design. Crap. Yeah, so anyway, we got that. And actually, they've kind of softened a wee bit, because there was a lot of people really annoyed with the MS Society for not supporting this, and they keep saying publicly, oh, we'd like more trials in LDN. You give them one to fund for 50k. It's really not a lot of money in research terms. It's not $500,000 or something. 50,000, no, not good enough. So we then went to the Chief Scientist's office with exactly the same proposal, no changes whatsoever, and they said, this is a great study. My goodness, fantastic. And, so good to get somebody doing some study on people rather than mice. That was the other comment they said. And so we're at the stage now, it's gone to there. They sent it out to 6 independent experts who have reported back, 5 of which said this is a good study and we should go ahead. 1 said it'd be better if there was a placebo arm, and we thought it'd be better if you read it. But, so we now had to make some changes, gone back out to these 6 to see if they're happy. And if the 6 wise men are happy, then we should get the funding and get started soon. So we're still awaiting confirmation of funding, but it is a long process. Linda phones me up about every 20 minutes and says, how's it going? Have you got funding yet? And I said, look, it's not like that, And she's beginning to understand. But she gets a lot of people in touch with her saying, what's happening? And a lot of people think we've just stopped because it took so long, that we've just given up on doing a trial in LDN, but we've not, and we're definitely going to do it. It's just a question of going through all these hoops, and, we'll get there. And then we'll have to recruit, and it'll not be easy, and, nothing is easy about this. But the prize at the end of it will hopefully be, an addition to the already, increasing number of studies that say what we are finding clinically and what you may be finding personally is real. Something's going on. Something really good's going on. And we have a drug here which is cheap. It's orally delivered. And it's, it should be very, very widespread. Skip kept saying he's banging his head against the wall. The one way we can do this is to get that sort of stuff out there. And it's still very difficult to get this drug. So, one of the good things about spending 4 years to get to this stage is you start adding in other things. You start thinking about other things, and you think, I wonder if we could do that as part of the trial. And that's what's happened with us. So in a way, it's been quite a good thing that it's been so slow, because we started thinking, what's the mechanism of action? And we had some talk about that this morning. And I'm going to give you a very different slant on what we think the mechanism of action may be. Nobody knows, but there's definitely an endorphin element to it. We know that. But is that the only story? Is there something else happening? May well be something else happening. And safety as well, we thought we'd do that. So we're going to do the standard blood tests. We're going to measure beta endorphins. That's very hard to do. There's no labs available to do it in the UK. So we started our own lab, not easily put off. We've opened our own lab, and we're going to do, the scientist assures us that she'll be able to make an ELISA test for beta endorphins.